one of these, but the first column gives you what the mean level is in the controls. And then the three methods that I mentioned. So a simple unadjusted regression that includes both the selection bias and the program effect, then our multiple regression estimates with the covariates controlled, and then finally the last column, which is our preferred set of estimates, are the inverse propensity weighted effects. So for example, in preterm birth, about 8.3% of the controls had births that were considered preterm. When we looked across the estimation technique, initially we don't see a difference between MCC recipients and non-recipients in the rate of preterm birth, but once we include better adjustments for differences in those characteristics, we actually see about a 1.8 percentage point decrease in the rate of preterm births, which over the baseline rate of 8.3% is a pretty substantial decrease. However, when we looked at low birth weight babies, again using the threshold of 2,500 grams, we found that we didn't find a difference between MCC recipients and non-recipients. So it seems that they're more likely to bring birth to term, but or pregnancies to term, but it's not showing up in a change in birth weight. And again, when we look at birth weight in grams, we see that consistent, that we only see 1 gram greater in birth weight among MCC moms in our sort of preferred model. When we look at prenatal tobacco use, it initially looks like that MCC recipients may have higher rates of use, but that difference statistically goes away when we use the propensity weighted effect. And in pregnancy weight gain, again, it looks like MCC recipients have lower pregnancy weight gain on the order of about 7 pounds lower, but that didn't reach statistical significance. I'm seeing a note that it's hard to hear the speakers. Let me pick up the phone. I'm using a speaker phone. I don't know if this is any better, but we'll try this. Let's see, so the next slide looks at some of the service use outcomes. If we look at the adequacy of prenatal care, about almost 80% of the control recipients were coded as having adequate prenatal care. When we again look by MCC status, we see that they're slightly more likely to have adequate prenatal care, but not statistically significant. So here we would say we don't find much of a difference between the two groups. We do find a large difference in the number of Medicaid-paid OB visits, however. The mean in the control group was about 11 visits, and we find that the MCC recipients, even after adjusting for risk factors, had about 3 more visits than did the control recipients. And it looks like a little bit of that is coming in the first trimester visit. So about 9% of the controls had Medicaid-paid OB visits in the first trimester, and almost 6 percentage points more MCC recipients had those kinds of visits. We also see greater use of WIC, which we were told in a set of interviews that we did with some of the service providers was sort of one of the main products of MCC services, is to get women engaged in mixed services. And we do see a pretty large increase, about 15 percentage point greater use of WIC services during pregnancy for MCC recipients. Okay. We also looked at primary care interactions, and we found that in our control groups, they had about 2 visits to their primary care provider during their pregnancy, but that women in the MCC group had almost 3 more visits than that, so more than doubled the initial rate. Emergency department visits, we actually were a little bit surprised by this result, but we found a small increase in the rate of emergency department visits. It's about 1/100th of a visit per woman, so certainly not a large increase in visits, but the fact that there was a larger increase in the MCC group was a little bit of a surprise, and we're still sort of puzzling over that result, and I would certainly welcome any comments that you all have on that. It may be that MCC led to sort of more attention being paid to health concerns for the women, and that may have resulted in a few extra emergencies.
Let me forward that, Eileen.
We finally looked at Medicaid expenditures. First, during the prenatal period, the average Medicaid spending for our control group was almost $600. And MCC recipients, because of having MCC services as well as sort of greater primary care and OB contacts, had about $250 more in spending during the pregnancy period. We also looked at family planning receipt and whether we saw any billed services for family planning during the first 3 months after delivery, and we again found a large increase in that rate by MCC recipients. We also looked at Medicaid expenditures during the first 3 months postpartum and also found an increase there as well. I didn't show you all of the service use that went on during the 3-month period, but we again found greater contacts with the health system. And in an underserved population, seeing expenditure increases is not necessarily a bad thing because it's probably indicating that more needs or fewer needs are going unmet. Okay, so in conclusion, we find that pregnant women who received MCC services had about a 1.8 percentage point reduction in the probability of delivering a premature infant, which again is a very large proportionate effect. But we didn't see effects in the actual birth weights or the probability of being low birth weights in terms of MCC differences. We do find evidence that MCC increased the proportion of women receiving adequate prenatal care as reported on the we do not find evidence that they're receiving greater prenatal care, but the adequacy rates were generally pretty high, so it's sort of hard to push an effect that's already pretty high. But we do find that women receiving MCC services had both greater contacts with specialty OB service providers as well as a primary care setting. And again, we're more likely to use WIC and family planning services after delivery, but also slightly more likely to use the emergency department during pregnancy. And we find overall Medicaid cost increases from MCC service receipt. I have some preliminary analyses that aren't reported in the slides that we've looked at some of the spending for the babies, and we actually see almost an identical amount reduction of the baby's expenditures. So if we consider mom and baby expenditures as sort of a whole package, it may be that that's sort of cost neutral in that regard. So we're certainly going to push on that issue further because that's an important sort of related set of outcomes. So a few limitations of the study. While we think this is a very rich set of linked data that certainly enhances a typical Medicaid claims data environment, there's probably a lot of important characteristics that we can't measure. We have limited information on medical status, generally only through what's reported on birth certificates or what's available in the Medicaid claims. We don't know anything about environmental factors, household characteristics, income, support that women have from, partners or family members is completely unobservable to us. Things like motivation to seek high-quality care we can't observe in our data. And so there may be some remaining biases between MCC recipients and non-recipients that this approach doesn't adequately target. And then there's lots of outcomes that we really wish we could have, like satisfaction with care, child health, cost to families in terms of time and transportation and caregiving expenses. We would love to have, but just don't have in this kind of a data set. So in summary, we see quite a few advantages to MCC service provision among the populations in our data set. And may indicate that there is evidence for greater expansion of MCC services to other high-risk populations. We'd have to, of course, deal with the cost effectiveness of the intervention, which we don't do here, except through Medicaid expenditures only. So, sort of a final footnote to this, as many of you know, North Carolina has since disbanded its MCC program and implemented a pregnancy medical home model in a state that already had a primary care medical home model. So some of these women who are already on Medicaid may be in two medical homes, one for their pregnancy services and one for their primary care and medical services. And so we'd love to do a follow-up study to see what effect that switch from MCC to pregnancy medical homes had, if any, on sort of a similar set of outcomes delivered here. So let me pause. I've given you a lot of information and I've probably talked much too fast. So do people have questions?
I'm sure our group has some questions for you, Marisa. So let's do that. If folks want to, if you want to type a question in or indicate on the chat box if you're online, you got a question, do that, and we can call on you. Otherwise, if you're on the telephone only, you might need to just pipe right up with your questions.
Glenn, there's a question from Margaret Knight. Margaret, if you're on, go ahead.
I can read it if she's not on the phone. It says, were those costs increased if you take into account the lower rates of premature births and the cost associated with caring for preterm babies? So that may have been a question that was asked before my comment. We only have Medicaid-based costs, so we have no idea, if the babies were delivered and then became, enrolled in a private health insurance scheme. We don't have that information, so we can only talk about the babies that were also on Medicaid at this point. But the babies of the moms who received MCC services did decrease over the study period, is what our initial analyses are showing us. We still want to do some specification tests and things that outcome. But it looks like the decreases, I think we're on the order of about $600 per baby, which if you add up the increases in the moms over the pregnancy and postpartum period, are really on a similar order of magnitude. Now, there are other things that we don't have, so some of the costs of having a premature birth, show up much later in sort of ongoing service expenditures. And so we're right now only looking, I think, at the first 6 months of Medicaid expenditures after birth. So we won't be able to model the longer-term cost in there except to bring in other studies that have done that. I see a number of people typing, but let's see. Who was providing the care coordination services? Was this conducted by local health department employees? Yes. So in our sample, 98% of the MCC services were provided by local health departments. Our data doesn't let us look at who exactly is delivering those services in health departments, but we did a set of interviews with some key informants at health departments and learned that these are mostly nurses providing these services, some with social work training or some social workers without medical training, but generally nursing staff providing these services through health departments. It was permitted, the project was allowed for MCC service provision by private providers and by FQHCs, but we saw very little of the services being provided from those types of providers during our study period. Let's see, I see a question. Do local health departments provide Healthy Start programs, and were these services considered in the study? I don't know the answer to that. I believe that they did provide Healthy Start programs. I am not sure that we have data on that because I'm not sure how that shows up in Medicaid data. So let me make a note to my co-authors to find out for sure on that, and I'm happy to follow up if you're interested in the answer on that, but I'm going to have to admit that that's not one I'm familiar with. I don't know if anybody is on the line that might have a better answer than I can give on that.
Marisa, didn't you have a slide or a bullet that said something about the higher rate of use of the Baby Love program. Was that Healthy Start?
Yes, that may have been Healthy Start. So that's one I'm going to have to look into exactly what we have on that. I believe that that is not through Medicaid claims, but I'm not exactly sure the source of data on that. So I'll have to look into that further. I'm just writing a note to myself to do that. It's a good idea to consider them, though. Let me scroll up and see. I don't know, Glenn, if you've seen any questions that I've missed. I've kind of been taking the last question.
Yet. One question I'd have, Marisa, I know I think your team was at least had some initial plans to look at issues around affect heterogeneity, or whether this program perhaps benefits some subgroups or segments of the population more than others. Can you talk a little bit about any work you may have done to look at treatment heterogeneity kind of issues in this context of this program?
Sure. I don't have any results to share on that yet, but we are hoping to have those soon. So we have been implementing a technique called patient-centered treatment effects, which is an instrumental variables technique that sort of accommodates the fact that, in this case, women with different backgrounds, be they race or ethnicity or rural-urban differences, may have different rates of enrolling in the program, and that difference in the rate of enrolling may also have an effect on the outcomes. So we're working with our consultant, who's an expert in this technique and has advanced its use in health policy, to try to come up with those results. So we're hoping that maybe in another month we'll have some results to share on that. But right now it's a little too early for us to have that finished.
Well, that's great to hear that work is moving forward. I think that's another very interesting methodological development, as you noted, that potentially has some utility in these kind of studies, these kind of applications. So.
Absolutely, and I'm really excited about those analyses. They're, considered sort of a more reliable way of getting at these subgroup differences or heterogeneity than just sort of pulling out women in with certain sets of characteristics and rerunning the analyses in that group. So we'll see. Some of it is, we've had some statistical issues with that because some of the things that we were going to use as instrumental variables turned out not to be as strong as we had hoped, the budget cut effect being one of them. So in that study we found that health departments just kept on delivering the MCC services even though their budgets were cut by about 20% during that study period. So good news for the pregnant women, certainly in our sample, and bad news for the statisticians in our group. Well, terrific. I'm happy to follow up if anybody thinks of questions or comments later. I didn't put my email address on the slides, but it's just domino@unc.edu, so please do shoot me an email if you have other questions or comments about it, because, as I indicated, we're trying to wrap up a number of papers in this area, and so we'd love to hear your thoughts and suggestions on this.
Fantastic. Well, thank you so much, Marie, for taking time to do this, and it's a great study, and we'll look forward to continuing to see results come out of the great work you're doing there with the PBRN.
Terrific. Well, thanks again for inviting me and letting me explain our results to you.
Glad to do it. Well, with that, why don't we transition to the keep moving along down our agenda. We'll move into the administrative component of our meeting today. We do have a number of issues to cover. First, the next item on our agenda relates to a new funding opportunity that was released by the Robert Johnson Foundation last week, and this is an opportunity being offered through our public health PBRN program. So it is a a targeted solicitation, an RFP solicitation that was released last week again, and is open just to our public health PBRNs, networks that are registered with the PBRN program. We are going to have a webinar next week to discuss this funding opportunity in detail, and so we certainly want to encourage you, for networks who have an interest in this opportunity, to make an effort to be with us next week when we have the webinar. It's scheduled, as you see here, on February 28th from 1 to 2 o'clock Eastern. We'll have an hour to talk about this opportunity in greater detail, but we wanted to just to make sure this was on your radar, and to give you the basics of this funding opportunity, to hopefully whet your appetite and entice you to read a little bit more deeply into the RFP. So this solicitation focuses on an issue that is an important component of the PHSSR research agenda, and one that is getting a lot of attention in recent months, and that is our gaps in our knowledge and evidence base about the cost of delivering core public health activities and services. This has been a component of the research agenda for a long time, but a number of developments over the last year have called attention to the need for better evidence around the resources needed to deliver public health services, and also the factors that drive cost, or that cause variation in the cost of implementing public health programs and services in different contexts. So this solicitation is designed to support research to answer those kinds of questions, to help us understand costs of public health service, and to help us identify delivery system features that affect those costs. There are two categories of awards. Awards, the first level supports smaller scale studies of up to $50,000 in total cost, studies that can be completed over a 12-month period, and then a second level of funding for somewhat larger scale, somewhat more complicated types of studies, up to $150,000 in total cost for those awards for studies of up to 18 months. There are certainly some other elements of the RFP, and so we encourage all of our networks to take a good look at this opportunity. And again, hopefully you can be with us next week when we have more time to discuss this opportunity in detail. Because this is an RFP solicitation, a representative from your network should have gotten the email notice of this award and the link to the RFP directly from the foundation through their solicitation process. With RFPs, that means this is a targeted solicitation, so the foundation is not releasing a broad public announcement for this funding. You've got to be a public health PBRN registered with our program to be eligible here. So that's the reason for the limited distribution and the targeted distribution of these RFPs. So the representative of your network should have gotten the link on that. We also sent an email out through our newsletter email list to networks as well, to make sure you know that's out there. If anybody hasn't seen this RFP, let us know. Send us an email to the PBRN account, publichealthpbrn@uky.edu, and we can make sure you get that announcement. The deadline on this is March 20th, and so in keeping with the Foundation's standard solicitation processes, we've got a relatively tight time frame on this. So want to keep that in mind as well. More details about the proposal and about the solicitation, the kinds of projects that we're looking for, again, are detailed in the RFP, and we can discuss those issues in more detail next week. But at this stage, we just want to make sure everybody's aware of this exciting new funding opportunity. Let me pause there and see if there are any quick questions or issues, thoughts from the group.
Glenn, this is Bill, Living Good. Just a quick question on if there's any kind of rough estimates on the number of Category 1 and Category 2 awards that will be given.
Yeah, good question. There's no there is an overall the foundation has an overall budget for these awards, but we're being somewhat flexible in terms of how many of each category. That'll be determined principally by by what kind of proposals come in and the mix and the quality of proposals that come in these two categories. I think as a rough ballpark, I think there's sufficient funding to fund about 12, maybe 12 to 14 awards, depending on the mix of the Category 2 and Category 1 proposals. So I'd probably say maybe the ballpark is more, 10 to 14, depending on that mix, how many of the larger award versus smaller award projects. Does that help, Bill?
Yes, thank you. it would help to get a little bit of an idea about I guess the proportion of Category 1 and Category 2, just in terms of trying to get a handle on how competitive. I mean, if you ask a little kid if they want 1 scoop or 3 scoops, they're all going to say 3 scoops. But if their selection of 3 scoops undermines their chance of getting anything,
right? No, I understand. Yeah, but really with this solicitation, there's not a hard and fast quota on the two categories. So I think I'd encourage networks in thinking about this to think about what kind of project your network is prepared to implement and has the qualifications to implement and has the opportunity to implement and try to make a decision in terms of thinking about the capabilities and opportunities that your network faces, because there's not a kind of a firm quota here. I think between the two categories, likely we'll see a relatively even number of projects funded in these two categories. I would imagine that would be my anticipation. Other questions or thoughts? Well, again, we encourage everybody to take a look at this opportunity. Again, it's tackling another important component of the research agenda. We haven't. This is somewhat of a new area for the public health PBRNs. We haven't had a solicitation to focus squarely on kind of cost issues historically, and that's one reason we're tackling it now. This will continue. This will continue to build capabilities in the public health PBRNs. Now, allowing you to build some qualifications in the cost and economic analysis area. But as we mentioned, this is also an area that is of considerable practice and policy interest right now, as we look at again issues around implementing components of health reform, looking at changes in federal funding for public health programs, looking at trying to address that IOM recommendation from last year to identify the cost of a minimum package of public health services, to efforts that are underway to develop a national chart of accounts for public health financing. Lots of policy and practice interest in in these issues, and so that's another important reason that we'll be sponsoring these.
Glenn, this is Elaine from the Connecticut PBRN. I just had a question, and that is, several of us, I'm sure, have submitted letters of intent for, I can't remember the title of the last announcement, the previous announcement, and we're waiting to know our status and whether we'll be invited to submit a full proposal. And I think that doesn't happen until later in March. You know what I'm referring to, correct? I'm sorry, I don't have the name.
Yeah, that's the again. Yeah, that was a funding opportunity, not through the PBRN program, but through
Right.
another component of RWJ's PHSSR agenda. Yeah,
Right.
I don't know
So
exactly.
the reason I ask is that it may be, depending on our status on that could influence what we would put in, or there could be complementarity for the, with the two, if you get both, if you know what I mean. And so I don't know if the timing, I guess, I don't know if we have any way to change the timing so we would know our status on that other submittal.
Yeah, there's no we've got no ability to influence the timing of that other solicitation. That's an open call, an annual open call for investigator-initiated research in PHSSR. It's got its own timeline and trajectory. I would say in that circumstance, and that's not uncommon
I know.
to be in that circumstance. My advice would be, obviously, synergy between projects is good, and so you can certainly emphasize that possibility in your proposal if your initial submission is still pending, and likely it's going to be. I mean, I don't think. I don't think you'll know anything for certain on that for until later in the year. But the flip side of that, anything you would propose under this initiative through the PRN program, you would want to have it be able to stand on its own and have it be a standalone project, so that if the other one doesn't come through, you can still do what you're proposing to do in this PBRN solicitation. So I think that's probably the strategy you've got to use in that circumstance.
Okay, fair enough.
Yeah. So, again, so we encourage folks to, to take a look and read this. Another question here from Mike Morris. Are the affiliates eligible? Yes, if you're a registered affiliate of the PBRN program, if you're registered with us as a PBRN affiliate, by the launch date of this initiative last week, you are eligible to apply, and so this is open. Yes.
If I can jump in quickly, this is Anna. Just to explain the RFP process with Robert Wood Johnson Foundation, an application has already been set up for each of the PBRNs. Whether they complete those applications or not is entirely up to the PBRN, but the invitation that went out to each PBRN rep links to an application that has already been started. And by started, I just mean there's a format set up. The PBRN has its name registered as an applicant. So all of the PBRNs that are registered with us already technically have an application in process.
Yep. Very, very good point. Yeah. And this is the process we've used for all of the prior PBRN solicitations. We always use this RFP process because it is a limited solicitation. So you want to make sure you've got that link that Anna referred to.
If anyone is unsure who your contact was and whose name it was set up, contact the coordinating center. We'll certainly get you that information. For the most part, program coordinators or very active PIs were set up initially. So if you have any questions, if you haven't seen the RFP and wonder in whose name that application is set up for your PBRN, please let us know, and we'll get that information to you.
Any other questions before we move on down our list? Excellent. Well, again, remember next week we'll have a whole webinar, a whole hour devoted to this opportunity, and we'll be able to discuss it in much greater detail. So we definitely encourage everybody everybody who's able to be with us on that session. Let's move on. Next up on our agenda is I believe we have Kate Papa on with us, and we have a special message about some special opportunities that are available to public health PBRNs through our colleagues at Academy Health. So let me see if Kate is with us.
Hi, Glenn. Hi, everybody.
Hi, Kate.
A special message. There's a lot of pressure. So thanks a lot for giving me some space on the agenda here, Glenn, and it was really great to hear from Marissa and her team, because I've been talking with many of the PBRNs. I think many of you know me from my emails, desperately asking for last-minute emerging science for some of the work Academy Health is doing here in Washington. So it's a great privilege to be on this call today, and I'm happy that I have money to give you guys, because Glenn just announced all this funding opportunity. It would be terrible to go after that unless I also had some money, or I know you all would be hanging up. So I have 4 things to say, but most importantly, I wanted to, well, I guess I should introduce myself. This is Kate Papa at Academy Health, and we're working really closely with the Coordinating Center to disseminate PHSSR here in Washington to policymakers. And like I just mentioned, we've gotten some interesting last-minute requests from agencies in Washington, which have often turned me into 2 o'clock in the morning, desperately emailing PBRNs asking what they have. Glenn tells me you have something great, and many of you have gotten these kinds of emails and responded really quickly, and are also working with me to fine-tune some of our key messages here to these agencies. So thank you, all of you, for being so responsive and for helping us do our job to get the research out there. So today I just wanted to announce a great opportunity. We also have funding from Robert Wood Johnson Foundation, and as part of our grant, they have given us some money to have a scholarship this year for PBRN representatives to come to Academy Health's annual meeting. So we have 8 scholarships available for folks from your PBRNs to attend the ARM, that's the annual research meeting, which is in Baltimore in June. And following the ARM is our Public Health Systems and Services and Systems Research Interest Group meeting. So it's a lot of research packed into a couple days in June in Baltimore, and these scholarships will cover registration to those meetings, as well as $1,500 in travel funds to attend. So we're trying really hard to make the application process fairly simple, because we really want you to apply, and we don't want to take too much time from your research and all these other opportunities you're applying for. So we're just putting the finishing touches on the application today. I'm sorry that it's not available to be sent to you this afternoon, but I'm hoping, let's say Monday to be safe. Might be ready by tomorrow, but let's say Monday, and I'll work with Anna and Glenn's team to make sure you all get the link. And all you need to do is send us an abstract of your work, and it's okay if your work is not complete, if your work is in progress, and just a very short paragraph about sort of why you should be selected, what you think you could get out of attendance at the meeting. So we hope you're excited, and we hope to see applications from you, and I am always here to answer questions. So with the link to the application, I'll also send along my phone number and my email, and people can call me at any time and email me at 2 o'clock in the morning asking me for questions about this opportunity. But I think it's pretty self-explanatory, and we hope there's interest out there. Should I pause for questions now, Glenn? Maybe I should mention the other big thing, because I think there might be questions about that also. Every time I see you, I'm afraid other people see me. I get this paranoia. I hope no one sees me right now. Okay, the other opportunity we have is not limited to PBRNs. It is going to be a translation and dissemination workshop that we are doing after the interest group meeting in Baltimore. It's just going to be probably a 3 to 4 hour meeting, and it's sort of a speed dating with journal editors that's what the foundation's calling it, not my phrase. So what we're hoping to do is bring in some research teams to kind of shop their idea, their study, their findings with probably I'm thinking five or six journals, and the journal editors, get a chance to sort of help you shape your message, your translation, your fine-tune your study a little bit so that you can sort of sell it to these journals. And I think this is supposed to be a very hands-on and interactive workshop, and it is going to be open to all PHSSR researchers. So again, it's not limited to PBRNs, but we're really hoping to see applications from you all for this opportunity. There is not registration. That workshop scholarship does not offer registration to the annual meeting, but it does offer a $1,000 travel scholarship. So we hope that that's enough to encourage folks to attend. And similarly, we are coming up with a pretty simple application, just telling us, what your research is, and we want to see research research teams that we think could benefit the most from the opportunity. So again, I'm happy to answer questions about these things.
Kate, hi, it's Elaine from Connecticut. How are you?
Hi, Elaine. Thank you for being one of those people who responds on Saturdays.
Well, yes, it was not 2 in the morning, though. But you have me beat. But I just had a quick question. And the way you were describing the scholarships for the Academy Health meeting, are you most interested in having the PIs on the academic research side attend, fill those scholarships, or the practitioners? It's not clear.
It's a great question, Elaine. We've talked about it a little bit. The scholarship is open to anyone, so we would love to see practitioners apply, from the teams apply for the opportunity, but we would also love to see researchers and everyone who calls themselves both. The annual meeting, for those who have never attended, is chock full of methods sessions, and methods workshops and methods seminars, and we have a range of sort of 101, 201, and 301 level. So I think anyone who's participating in the kind of work the PBRNs are doing is sort of certainly qualified to come to the meeting and would hopefully benefit from it. So I hope to see a range of interest from a range of people.
Thank you. I guess my question was to who would benefit the most? How would the PBRNs benefit the most by?
Well, we talked a lot with our friends at NACCHO and other and the public health practitioners themselves, and at least at Academy Health, we feel like to be using the research, right, or the PBRNs, you practitioners are actually doing the research too. You have to be able to understand it enough. So I think that Glenn might be able to speak to it because I know he's a long-standing, long-term attendee of the ARM. But I think that there's sessions at the annual meeting that would certainly be of great interest to public health practitioners. And this year, because we're in Baltimore, I should add, we had the largest number of submissions ever in our 30-year history. Oh. We're anticipating, there's many reasons why that could have happened, but one of them is certainly our location was so close to D.C. this year. So we're expecting that many federal agencies who don't normally have travel funds to attend will be coming, and that the meeting will have a particularly heightened policy sort of bent, so there'll be many more sessions even than ever about health policy.
Great, thank you.
And Bill Living is asking about deadlines for applications. Do you know anything about when the deadlines might be?
Well, I don't want to announce it till Glenn approves. I have April 1st on my draft here, but I don't want to squeeze everyone and make you feel too rushed to get this in. So we could be, what do you think, Bill? Does April 1st sound too rushed?
That sounds great to me.
Okay. We'll make sure by the time we get the materials ready for folks that you have at least 4 to 5 weeks to get everything in, and that if you're going to be at Keeneland, that we'll take that into consideration as well, and not obviously put the due date in the middle of the conference.
Great. Well, Kate, these are both very, very exciting opportunities. Thank you so much for working with us to make these happen. And yeah, definitely, I can give you nothing but good things to say about the Academy Health, the main annual research meeting, as well as the Public Health System Research Interest Group meeting. I agree. The relevance to more research-oriented PBRN collaborators, as well as practice partners who are actively involved in your research network. I think both flavors of colleagues will find the meeting to be very much of interest. And I think for the interest group meeting in particular, I think we've seen an increase over time in the participation from practice-oriented colleagues that has really contributed to the dialogue and discussion in the interest group in particular. So.
Yeah, thanks, Glenn. That reminds me that a couple of things, two of which I forgot. But we've already had great interest from a whole subset of public health practice community in the Maryland, Baltimore area from community health centers and others who just already found out about the meeting. So I do think it's going to have a certain flair this year. And I should remind you now that I've been given a mouthpiece, which you might be regretting, that our call for nominations for Article of the Year award is still open. That closes March 1st. And so if you're really needing money, you could apply for everything and win and get all this money, because the Article of the Year award winner actually receives a $1,000 cash prize, but also travel funds to come to the meeting. And we thought a little bit about, what if somebody does win all of these, and this is the first year, so let me just be frank. I don't know if I'm organized enough to even keep track of that. So go ahead and apply and nominate your research team or your colleagues who've published some great work for this Article of the Year award, because that's another way to, the winners do receive travel stipend to come to the meeting. And we just, we want all these opportunities to be ones that are appealing for you all, and that will give you opportunity to attend this, educational and training sessions. And just one quick thing, Glenn, we will be doing a session at Keeneland, and it's the pre-Keeneland session for the grantees. So this session we've been working really closely with Glenn and his folks on. It's going to be focused on translation and dissemination, and it's not going to be, so let me back up for a second. The workshop I mentioned with the travel scholarships in June is particularly focused on dissemination in journals, like I mentioned. So we're going to, sort of more traditional peer-reviewed journal publication is the focus of that June workshop. For our Keeneland session, we're going to talk, more broadly about translation and dissemination and the multiple vehicles that you should be considering in disseminating your work along the way. So from the very beginning, the middle stage, and the end. And it's going to, we're planning a very interactive session at that, and it's the 2-hour session at 9 to 11 right before the opening session at Keeneland. So we hope to see you all there.
Fantastic, Kate. Again, thank you so much for all the great work you're doing on behalf of the field and for our PBRNs.
Well, keep sending me stuff. If you don't know me yet and I haven't found out about your great research, email me. And poor Elaine and others know that once I know your name, I never lose it, and I beg you to participate in various things. But if you're doing great work that I don't know about, and I appreciated hearing from Marissa and her team, send me an email, introduce yourself, and tell me what your team is working on, because I like to know all those things. But if I've said too many things today and it's all getting mushed up in your head, go ahead and just give me a call, and I can walk you through these opportunities and make sure I answer all your questions.
Fantastic. I know that we have folks who will take you up on that, Kate.
Okay, great. Thanks.
Thank you. Excellent. So we are right on schedule, and still have a list to go through here. Let's talk about our next topic, which is also on the topic of funding and sustainability opportunities. Just a couple of comments to make about additional opportunities out there on the horizon. Obviously, we profile the funding opportunities that we're aware of that come across our desk every month in the PBRN newsletter. So and you'll be getting another one of those next week, so make sure you stay attuned to that. In particular, we mentioned this last month, but we want to keep it on your radar screen. One opportunity that's on the street now that we think is particularly good for PHSSR investigators and particularly good for public health PBRNs is the renewed program announcement for the dissemination and implementation research out of the NIH portfolio. Dissemination and implementation science program announcement out of NIH. We definitely encourage you to take a look at those opportunities. There are several different categories of awards, RL1s, R21s, so larger scale research as well as some smaller scale, more developmental research opportunities there. A number of different institutes within NIH are participating in that. So in terms of what disease areas or health risks are relevant to study, you've got a number of degrees of freedom there. So this is something that we'll want to, we think that will be relevant and of interest to many of our networks. So check that out. Again, the link to those awards are profiled in the newsletter. We actually had a chance to talk with Russ Glasgow, who is at the National Cancer Institute and who heads up this D&I enterprise, one of the leaders in the D&I enterprise at NIH, and talk specifically with him about the kind of work that's happening through our PBRNs and about where some of the points of connection will be. And so on the basis of that conversation, we're really enthusiastic about this particular funding initiative for the PBRNs. And likely we're going to spend some time at our grantee meeting at Keeneland talking about the D&I research in general and how it's relevant to PBRNs and the PHSSR, and maybe more specifically talking about some opportunities for multi-network research and multi-network research ideas in the context of that opportunity. So we'll carve out some time from our grantee meeting to talk about that. But definitely take a look at those opportunities if you haven't seen them yet. Another funding opportunity, sustainability opportunity that I'll mention just briefly, and this is based on a trip I had to CDC late last week. I had the chance to. I was invited to give the grand rounds for the National Center for Injury Prevention and Control at CDC. This is their 20th anniversary of that center being a part of CDC. And I was invited to come out and talk a little bit about what's happening in the field of PHSSR and what's happening specifically in our PBRNs to that audience of injury prevention and control experts at CDC. And then spent the rest of the day largely with folks at the Injury Center talking about what kind of research they're doing and quite frankly talking about the growing interest of CDC's Injury Prevention and Control group in PHSSR. The Center Director, Linda DeGutis, is in the midst of reorganizing that center, and part of that reorganization involves building capacity for doing PHSSR and for thinking more comprehensively about injury prevention and control in the context of public health delivery systems. I came away from that meeting on Friday, just back on Friday, pretty enthusiastic about emerging opportunities for collaboration and synergy with CDC in doing PHSSR relevant to injury control and prevention. So we wanted to put that on your radar in general, so that you can be thinking about who in your network might be interested in issues of public health responses to injury and public health responsibilities in injury prevention and control. Is this an area that your network might have some interest in? Is this an area where some of your network members may already have some expertise or experience on the practice side, on the research side, that could be relevant here? Because we're going to I agreed on Friday to continue to work with CDC and with folks in the Injury Center around some opportunities for collaboration over this next year. We're thinking about doing perhaps some joint webinars where we would invite our PBRN colleagues as well as colleagues, CDC colleagues and colleagues in the CDC-funded injury research centers around the country to participate jointly in identifying some opportunities for collaboration and synergy. I also invited the folks from the Injury Center to come down and be a part of our Keeneland conference and maybe even carve out some time during our grantee meeting to hear a little bit from CDC colleagues there. And we talked about some other opportunities as well. So this is still very much a work in progress. It's a conversation we'll be having with CDC over into the future, but we wanted to go ahead and plant that seed with you, and so that you can begin thinking about whether this is an area that your network might have an interest in. It's obviously an area that the issue has gotten a lot of new attention. Unfortunately, in response to the episodes of gun violence that have played out around the country recently, and obviously President Obama's announcement, his executive order giving CDC new emergency funding to reinvigorate their research program in violence research in particular, has given this area obviously some enhanced visibility. And that's relevant. That area of gun violence is certainly relevant to public health and PHSR, but we're talking about the larger portfolio of research in injury prevention and control as well. So those are a couple of quick updates in terms of thinking about new funding, new areas of growth that might be useful for your network to think about in terms of growth and sustainability. Any quick questions on that before we move ahead?
Glenn, this is. Go ahead.
Just this is Elaine again. Just a quick question. I think about PCORI. There's been a lot of conversation here at Yale about that funding mechanism. Are you aware of many grants that are going out from PCORI for PHSSR type research?
Well, I think the short answer is I think that the jury's still out. There's only been 2 cycles of awards, so far out of PCORI, the pilot grants and then just the first cycle of larger awards. I am aware of one, actually two awards, two initiatives that got funded in the last cycle that have some PHSR in them as a component of the work. One project that was funded here at UK that is focused on cardiovascular delivery of primary prevention strategies for cardiovascular disease in rural areas that involves some work with the public health delivery system, and then another project that was funded actually in Arkansas with some former colleagues I work with there that is looking at using a kind of a community deliberative process to target interventions that involve the public health system as well as the mental health system in rural areas. So there are a couple of examples I can point to just because I've got some personal connections to them. More generally, we've had an ongoing conversation with colleagues at PCORI and directly with Joe Selby about their interest in funding projects that include studies looking at delivery of upstream prevention and public health interventions, as well as their interest in obviously in downstream treatment and therapeutic interventions. So I can tell you that there's absolutely an interest, and that's why Joe Selby, head of PCORI, is going to be with us at Keeneland. He's giving one of the keynotes. He's coming in time to meet with our National Advisory Committee and to brainstorm with us about how we can work collectively together. And he'll give the keynote address on Tuesday night, I believe. So there's absolutely an interest. Whether we've gotten a critical mass of projects funded yet, probably not. But the door's open.
Thanks.
Glenn, this is Chris Malin. I just wanted to mention one other thing that you may or may not be aware of. When Paul Halverson was president recently at ASTHO, he issued a presidential challenge on motor vehicles motor vehicle accidents as an injury focus. And during the year that he was president, both ASTHO and CSTE did webinars for state health departments on sources of data and evidence-based interventions for injury that are now cataloged on the websites of those two organizations. And then secondly, as part of the Affordable Care Act, ASTHO got some money to promote evidence-based interventions and brought in the injury folks to describe the evidence base around injury prevention. That also is housed at ASTHO. So I think anyone that might be interested in working in these two areas could find some resources at both ASTHO and CSTE for work that they might do.
Excellent point, Chris. Thank you. Thank you so much for bringing that up. That's great to know. We'll make a note of that and keep that in mind as we move forward on that. So stay tuned. If you've got an interest in this area of injury prevention and control, stay tuned and feel free to let us know, because we are going to be working with CDC over the next few months to tee up some opportunities in this regard.
Glenn, I think one of the key people is Randy Elder.
Uh-huh.
Who could be a contact. He was the one that spoke most eloquently around the community guide. I think was involved in some of the intervention research around the community guide and injury.
Absolutely. Yep. That's great. That's great. Thank you, Chris. So with that, why don't we go ahead and unless there are any other burning questions or comments on that, on any of those topics, emerging issues in funding and sustainability. Let's go ahead and move into talk a little bit about our planning for our annual grantee meeting, the PBRN grantee meeting in conjunction with the Keeneland Conference. So let me see if Lizette wants to take over and on this point.
That's fine, Glenn. Thank you. I just want to remind everybody, of course, our annual grantee meeting is coming up we'll begin early on Monday morning, April 8th, and we'll go through noon on Tuesday until the beginning of the Keeneland Conference. And I know that in the last two newsletters, both December and January, we have talked about our travel policies. I just want to bring that to your attention again. I know that many of you will obviously be attending both meetings, and there are different travel policies and guidelines for each of these meetings. If you are working with the PBRNs and you are going as the PBRN representative, you have to follow our PBRN guidelines for reimbursement. The PHSSR National Coordinating Center has different guidelines. By now, I've gotten most of the names of the representatives from PBRN. I'm still waiting on 4 of you. Don't worry, I'm not going to call you out. But we do need to have that information as soon as possible. Later this afternoon, I will contact each of the representatives from each of the PBRNs, and I will give you specific information on who you need to contact to set up your travel arrangements. We will only be able to reimburse you if you book your travel through our travel agents. Again, we're doing this to control our budgets and control costs during these tough economic times. We want to make our resources last as better as we can to provide you with more opportunities. We do still have some funds available for those of you who will be presenting at the Keeneland Conference. I do know that all abstracts have been reviewed, and we've received a list of presenters from the Keeneland Conference Planning Committee. I believe they are in the process of contacting presenters and letting them know what the schedule is when we'll present. If possible, could you please email the PHPBRN Center and let us know if you are presenting and when you will be presenting. Obviously, I recognize a lot of the PI names. There are some practitioners who I'm not so familiar with. See that name and I don't realize it's a PBRN practitioner. I might not know that. So please do email me and let me know that. Let's see, what else can I tell you? Yes, so again, March 1st is the deadline for your network to contact us with the name of the representative. So please let me know that information as soon as possible. I do understand that flight schedules are tight. We have a lot of people flying into Lexington during April, and especially during the week of the meeting. So the sooner you can get your reservations, the better. And so please contact me with any questions. Anna, do you have anything to add?
I would just add that please do get her that information on who your PBRN's designated traveler is by March 1st, because after that date, any unclaimed funds are going to go in the pot to help support anyone who's staying through Kingland. So if you want us to help fund someone's travel on for the grantee meeting, please do let us know by March 1st so that we can make sure that everything is taken care of and all the I's are dotted and the T's are crossed. Those presentation schedules, we do appreciate those, because what we really want to do is let you all know in advance of the meeting, in advance of the Keeneland meeting, where your colleagues in the PBRNs are presenting and at what time, so that you have something on paper or on your BlackBerry, if people still use BlackBerries, or on your iPhone that lets you know, yes, I have a PBRN colleague presenting right now over there. So that will help us make sure everyone knows you're presenting where and when, and promote your sessions. Glenn, did you want to talk a little bit about the overview of the meeting?
Sure. Yeah. Well, we are advancing our work and putting together the agenda for our PBRN grantee meeting. That again will be mostly happening during the day on Monday, and then there's some activities Tuesday morning that where our PBRNs will be intermingling with other RWJF funded initiatives. So our planning for that for our grantee meeting is well underway. We've got some really good opportunities teed up for you, but we want to hear from you. And so if there are some issues that you'd like to address, some things you want to put on the agenda to see if we can accommodate on the agenda for our grantee meeting, now's the time to let us know that, as we're tweaking that agenda and making some final decisions on that. So let me send out an appeal. If you've got a great idea, or if there's a topic that you would really like to see addressed, or an idea for some other kind of activity that you'd like to see as part of our PBRN grantee meeting, and likely it's going to need to be something we need to figure out room for on that first day, on Monday, April 8th. Let us know. If you got an idea you want to share with us in the next couple of minutes, feel free to do that, because we're going to just be opening up for general questions here. But if not today, please send us an email or give us a call over the next couple of days with your idea or thought or question. As we're going to be working through the end of this month and to hopefully tighten up and finalize that agenda, and we want to be able to send you out at least a tentative agenda of our grantee meeting early next month. So any thought? We do have a couple of minutes. Any thoughts that people want to have about, or ideas you have about the grantee meeting, activities that you'd like to see, or topics you'd like to see addressed at this stage?
Glenn, it's Elaine again from Connecticut. One topic that I think is of great interest is what can we begin to assess the impact of the PBRNs thus far on, what have we generated in our research that can be applied in policy and practice, and it goes also to the dissemination issues, and when Kate reaches out and she wants information from policymakers, I'm just thinking of looking at everything that we've done collectively, and are there examples where we actually had projects that have already had an impact? I mean, that's of tremendous interest to all of us, and certainly to practitioners.
Absolutely, that's a great topic.
I don't know. I mean, if we could call out some projects that could speak briefly, or because I mean, we can talk about sustainability and the things that we've talked about every year, but I think we're at the point where we should be looking more at our impact.
Yeah, that's a great topic. We can certainly think about how we might touch on that in our grantee meeting. But I'll also mention we're planning a special session for the closing session of the main Keeneland conference to also highlight those examples, similar to what we did last year. Where we had I think 4 case studies of applied PHSR research and heard from both the researcher and the practitioner sides in terms of how that research is being used. A couple of good examples I thought we heard last year. We're gonna have a very similar kind of session for our closing session of the main meeting as well to do that. But that's a great point, Elaine. Other thoughts?
Maybe for those that aren't going to stay for the whole conference, maybe even some abbreviated something or
sure.
That. I don't know.
Absolutely.
I would also, this is Anna, and I would also just point out that we are also part of that broader Academy Health Dissemination and Translation workshop on Tuesday morning that Kate mentioned earlier. Leading up to that, after our Monday sessions and before the Tuesday morning workshop, the World Cafe is going to be focused largely around D&I issues. So we'll be coming together in that World Cafe format that you may remember from last year. And the different tables will have questions targeted toward D&I. So we're hoping that we can begin laying the groundwork for that Tuesday morning workshop on Monday night. Okay. And we'll certainly give some thought to where else we can put D&I into the program and translation, because those are obviously areas of great interest to us at the Coordinating Center as well.
Absolutely. Other thoughts or questions, ideas, comments?
Well, sorry if you keep interjecting. This is Elaine again. I don't want to.
Hey, that's all right.
I just wanted to ask, since you are funding one person this year per PBRN, is there a limit on how many PBRN members you can accommodate at the grantee meeting? Because some PBRNs will have other people who can attend using other resources.
That's a great question. My inclination is we want as many PBRN members as we can, but as we can possibly accommodate. Is there? Let me turn to Lizeth or Anna. Do you know? Is there are the fire marshals going to close us down at a certain number?
I don't think so, Glenn. Now, we did invite the PBRNs who had active RWJF funding during the year, so that did limit some PBRNs who did not happen to have funding at that time. Were not the PBRNs that we were going to cover travel for. However, of course, everybody, we would love to have as many attendees there as possible. We are also trying to look at the feasibility of using Adobe Connect during some of the sessions so that we can have some participation, real-time participation with folks who aren't there. But this is obviously going to depend on room setups and things like that.
But you would want to know who is coming, right, in advance?
I think that would be nice to know.
Yeah, because I mean, regardless of who we're funding, if you've got other folks coming, if you could let us know, that definitely helps with planning.
From a spatial standpoint, I don't think we are going to have any issues because we actually have space reserved that's larger than last year's, and I'm very happy to report that is not in the black hole of Calcutta that we were in last year. So we will be in a ballroom on the main floor, and we should have plenty of room.
We're not going to be in the underground bunker like we were last year.
And hopefully we will not have the giant spaceship projector.
Right. So the short answer is we will make every effort to accommodate as many of your PBRN members and colleagues as you can possibly muster to get to Keeneland. You know, we wish we had more resources to fund more than the one person per network, but we invite as many of your colleagues who are able to join us as you possibly can, because it's a great meeting, both our grantee meeting and the larger conference.
Okay, thanks.
Any other questions or thoughts? Closing shots here. I know our time is nigh. Well, thanks again, everybody, for being with us and for another great meeting. We obviously have a lot of things on the agenda, a lot of exciting things on the horizon. So we'll look forward to continuing to stay in touch on these. And again, let us know if we can be helpful. Give us a shout, shoot us an email, and we'll be glad to connect. So long, everybody.
Bye.